All right, hello. We're going to go over cardiac pharmacology today, and this presentation is going to be everything you need to know, but maybe we're afraid to ask. So I'm going to go over all of the drugs that we give to patients who, I'm recording. It's okay. So we're going to go over all the drugs that we give to patients who are having arrhythmias, and we're going to go over what they do so you understand what they do. And we're going to go over how they work. So let's get to it. To begin, whenever we're going to give somebody a drug, we want to understand what type of problem we're trying to address. And I have simplified this for you as much as I think is possible. There's a great quote from Albert Einstein that said whatever system you're using should be as simple as possible and no simpler. So I think that is what we have here. So we're talking about what the problem is with the heart. It's either too slow, which means heart rate less than 60, too fast, which means the heart rate's greater than 150, or too ectopic, which means that the electrical activity isn't originating from or going to where we would like it to go. So too fast, too slow, or too ectopic are really the only three things that you need to worry about being wrong with the heart rhythm. And you can very simply, by looking at the monitor, determine which of these categories you're in. If the heart rate's less than 60, you're too slow. If it's above 150, you're too fast. And if the squiggly lines aren't squiggling the right way, then you're too ectopic. So if we continue with this, this is the schema, the map that we're going to be looking at as we work through this together. So we have basically the atria and the AV node. We have the ventricles, and then we have the vasculature. And when we give drugs to our patients, the drugs are going to affect either the atria, the AV node, the ventricles, or the vasculature. And we're going to talk about the different drugs and which drugs affect which parts of this schema and how. So let's take a look. These are our drugs for when we have a heart rate that is too slow. That's atropine, epinephrine, dopamine, norepinephrine, and then kind of in parentheses here on the bottom, we have calcium and we have sodium bicarb. So let's start with atropine. So atropine is going to be a drug that we can use to treat sinus bradycardia, first-degree heart block, and second-degree heart block type 1. And for these rhythms, we have an electrical impulse starting at the SA node, traveling down to the AV node, and then down to the ventricles. But the SA node is just firing more slowly than we'd like it to fire. It's too slow, as you can see up here, indicated by the red arrow that says too slow. So what atropine is going to do is it's going to act at the level of the SA node to increase the firing rate of the SA node. When the SA node fires in these rhythms, the impulse is reliably transmitted through the AV node down to the ventricles, and so we're able to increase the ventricular firing rate. Guys, as we look at this, remember the heart rate is determined by the rate at which the ventricles are firing. I'm going to say that again. The heart rate is determined by the rate at which the ventricles are firing. So that is always our primary concern. We're less worried about the P waves and more worried about the QRS complexes in terms of keeping our cardiac output up. So when we have a sinus rhythm, a first-degree heart block, and a secondary heart block type 1, we can use atropine to increase the SA node firing rate, increase our heart rate, and therefore normalize our cardiac output. Now let's look at this next slide. And in this next slide, what we have is secondary heart block type 2 in third-degree heart block. And for secondary heart block type 2 and third-degree heart block, the situation in the heart is that the ventricular firing rate is not being determined by the SA node anymore, because your impulses are being blocked at the level of the AV node. So in second-degree heart block type 2 and third-degree heart block, you have the ventricles themselves that are determining the firing rate. So what this means is that increasing the intrinsic rate of the SA node doesn't help us in second-degree heart block type 2 and third-degree heart block, because it's not the intrinsic firing rate of the SA node that's determining our heart rate. So we're not going to use atropine, or at least it's not going to be effective if we try to use it for second-degree type 2 and third degree. Now, there are some protocols that don't really trust us paramedics to distinguish between second-degree 1 and second-degree 2. So there are a lot of protocols out there that just say to give the atropine anyway. That's a judgment call as to whether you're going to just rigidly follow your protocol or not. I certainly wouldn't blame you for just following your protocol, but understand, if you know your patient's in second-degree type 2 or third-degree heart block, the atropine is not going to be effective at improving their heart rate. So, all right, let's look at our next drug. Our next drug is a big one, epinephrine. So epinephrine for bradycardia works in 4 different ways to improve cardiac output and blood pressure. Epinephrine increases the firing rate of the SA node. It increases the conductivity and velocity of conduction through the AV node, and it increases the firing rate of the ventricles. As well as those effects on the heart, it also has an effect on the vasculature. It causes the blood vessels to constrict. So what does this do? Well, if the heart rate is being determined by the SA node, then its effects at the level of the SA node are going to increase the heart rate. If the heart rate is being determined by the intrinsic rate of the ventricles, as in second-degree type 2 or third-degree heart block, then the epinephrine is going to increase the ventricular firing rate and increase the heart rate through that means. Regardless, and aside from what it does to the electricity traveling through the heart, epinephrine is also going to constrict our vasculature. And because of the laws of pressure, when we have fluid that is going through a smaller lumen, its pressure is going to increase. So as a result of that, when epinephrine causes vasoconstriction, that causes a direct increase in blood pressure, which is very helpful for these patients if they have diminished cardiac output secondary to bradycardia. Okay, so that's epinephrine. Again, epinephrine is a big one, and epinephrine is kind of your only option for a pharmacological intervention for second-degree heart block type 2 and third-degree heart block, at least in terms of something that can increase the heart rate. There's other drugs that we can give that will increase the blood pressure in those situations, but epinephrine is our drug of choice for increasing the heart rate. Now, if we look at dopamine, dopamine is kind of a tricky drug. So dopamine is somewhat dose dependent. So what that means is that it's thought that dopamine at doses of 2 to 10 micrograms per kilogram per minute has a primarily chronotropic effect. What that means is it increases the heart rate. And I have to walk back something I just said, which is that you can also use dopamine to pace the heart. It's not our drug of choice, but you could use it to pace the heart in second-degree type 2 or third-degree heart block. It can be used. It's falling out of fashion, but it can be used. And you're going to use it at the chronotropic level, right? So you're going to use it at a dose range of 2 to 10 micrograms per kilogram per minute to pace the heart. Now, at higher doses, so this is 5 to 20 micrograms per kilogram per minute, you get vasoconstricting effects of the dopamine predominating, which means dopamine acts primarily as a pressor and less so on the heart rate. Notice that in the range from 5 to 10, you have kind of a gradual transition from primarily chronotropic to primarily vasopressing effects of dopamine, right? Primarily vasoconstricting effects of dopamine. Dopamine is kind of an old-fashioned drug, and again, it's going out of fashion. It's kind of a blunt instrument. It does, as you can see, it does a lot of different things, and it doesn't do really any of them better than any of the other more targeted agents that we have. So one of those other more targeted agents is norepinephrine. So norepinephrine is its effects can be described as pure alpha. So where are our alpha receptors? Our alpha receptors are in the vasculature itself. So norepinephrine is pure alpha. It doesn't affect the heart rhythm or rate. What it does is it vasoconstricts. That's what norepinephrine does. Norepinephrine vasoconstricts. So if you have somebody who's maxed out on heart rate, but is still hypotensive because of a container size problem, norepinephrine is going to be your drug of choice. So when is this going to be the case? Well, think about patients that are tachycardic and still hypotensive. The best example I can give you of that, the kind of classic example, is a septic patient. Septic patients are going to be in sinus tach. They're going to be trying to maintain their blood pressure by increasing their heart rate, but they're not going to be doing a great job because all the waste products that are building up in the body are going to be causing widespread vasodilation. So what do we do to counteract those effects? We give a pure alpha agonist like norepinephrine to cause vasoconstriction and help us keep that blood pressure up without making the heart even more tachycardic than it already is. So that is why norepinephrine is our drug of choice for septic shock. Okay, so the next two drugs that we're going to talk about can be used in various situations when the heart is either too slow, too fast, or too ectopic. So these kind of cut across all the categories, and they can be used in a wide variety of situations when we're correcting the specific type of problem that these drugs correct. So hyperkalemia and acidosis are the two problems that these drugs are capable of correcting. So how are we going to recognize hyperkalemia in the field? Well, we don't have lab values, so we have to do it based on history. And there are some findings we can look at. So what sorts of histories are associated with hyper-K? Well, one is a dialysis patient that's missed dialysis. That is somebody who is hyperkalemic because potassium is built up in their bloodstream due to having missed dialysis. So that's number one. Number two would be potentially a diabetic patient, an insulin-dependent diabetic patient who hasn't had their insulin. Remember, insulin works using the sodium-potassium pump. The sodium-potassium pump shifts potassium into the cells. If that sodium-potassium pump isn't working to shift glucose into the cells, then glucose and potassium are going to build up outside the cells. That's why these patients become hyperglycemic. And along with that hyperglycemia, they get hyperkalemic. So what are you going to see to recognize this? Well, you'll see peaked T waves on the 12 lead, and you will see perhaps, especially in the case of diabetic ketoacidosis, you'll see Kussmaul's respirations as the respiratory system tries to compensate for metabolic acidosis. So in addition to this, in addition to hyperkalemia, we might see a patient who's acidotic. So diabetic ketoacidosis would be one reason, but other reasons could be sepsis. Other reasons could be opiate overdose could make somebody acidotic. Toxins could make somebody acidotic. You might also see somebody who is experiencing, for example, a sodium or a tricyclic antidepressant overdose. So these sorts of things will cause acidosis, and they also, one of their features is that they poison the sodium channels in the heart. So this creates a sodium channel poison condition, and one of the things that we absolutely must resist the temptation to do is to give sodium channel blockers like lidocaine and amiodarone, which we'll talk about in a minute. So this is going to present with a really wide complex tachycardia. It's a QRS greater than 0.2 seconds. So if you see that, that indicates hyperkalemia or acidosis, and we're not going to give sodium channel blockers for that. All right, but let's put a pin in that for now. We're going to come back to that, and let's consider calcium chloride. So calcium chloride, we have these in this case, right? We have these really wide QRSs. We have a fast rhythm. So this is indicating to us, these really wide QRSs is indicating that we're either in hyperkalemia or acidosis. We have a sodium channel poison condition. We're going to give calcium chloride to stabilize the sodium channels. And as we give the calcium chloride, we're going to see our QRS complexes narrow right up. Along with the calcium chloride, we are going to give sodium bicarb. And similarly, that's going to stabilize our sodium channels and help normalize those QRS complexes. Now, notice the chemical formulas for calcium chloride and sodium bicarb. And if you put those two together, they're going to combine to make calcium bicarb, which is also known as chalk. Chalk is not something we want in the veins. So to avoid making chalk in the veins, we're going to make sure that we flush really well in between giving calcium chloride and sodium bicarb. Okay, I know this is a lot. I know your head might be spinning. Bear with me. Let's move on, talk about our rhythms that are too fast. So the first drug that I want to talk about with you is adenosine. All right, so the first drug we're going to talk about is adenosine. So for adenosine, this is our drug of choice when we have supraventricular tachycardia. So we have to understand what's going on with supraventricular tachycardia in order to understand how adenosine works. So remember, with supraventricular tachycardia, most of the time, what we have is a re-entry loop at the AV node. So we have electrical activity that is getting conducted through the AV node and then reflected back up to the top of the AV node. So you have a re-entry loop. It's like a record that is continually skipping back to the spot it was previously in and repeating. So you get this repeat loop. So what adenosine does is, very briefly, it blocks all activity at the level of the AV node in order to get the heart out of this re-entry loop. It's like jostling a skipping record to get the needle out of the groove it was in and into another groove so that it can continue playing. So that is what adenosine does, and it is our drug of choice for stable supraventricular tachycardia. Beta blockers act at the level of the SA node. So adenosine, I want you to think of it as acting primarily at the level of the AV node to block reentry. Beta blockers act at the level of the SA node, and they suppress activity. They lower the intrinsic firing rate of the SA node. They also lower atrial excitability. So for inappropriate tachycardia, an example of this would be a patient who is having a stroke and their blood pressure is higher than we would like it to be. We can use beta blockers to lower the firing rate of the SA node and therefore lower the blood pressure. This is why beta blockers can be used just as a maintenance medication for people with high blood pressure. It just keeps the heart rate under control. By the way, beta blockers can actually also be used for conditions like anxiety. If people get very anxious and their heart starts to race, beta blockers can control that anxiety and prevent their heart from racing. The other thing that beta blockers can be used for is for rate control in atrial fibrillation with rapid ventricular response. So remember that in AFib, what we have is a storm of electrical activity going on at the level of the atria, and the beta blockers that we give will just kind of suppress the intensity of that storm, and hopefully by doing that, we will lower the extent to which the ventricles are responding. And you can see that happening here. We have a very fast atrial rhythm on top, and then we've suppressed the intensity of the atrial storm, and we have a slower ventricular rhythm. And remember, again, this is all about the ventricular rate. That's what's going to determine our overall heart rate. The other thing to remember with beta blockers is over here, the lungs. So what do we use to treat asthma? We use beta agonists like albuterol. Remember that beta blockers don't just block the beta receptors in the heart, they also block beta receptors in the lungs. So not just beta 1, but beta 2 as well, which means that if you give somebody who has bad asthma a beta blocker, you are potentially knocking out our ability to bronchodilate them very effectively. So this is a drug that needs to be used with extreme caution in patients with COPD and asthma, because we don't want to knock out our ability to bronchodilate if we need to, if there's something else going on. All right. Calcium channel blockers. So I want you to think of calcium channels as predominating in the AV node. So we can think, if we're going to talk about the electrolytes in the heart, and this is dramatically oversimplified, but if you have this mental map, it's going to serve you just fine for being a paramedic. So I want you to think of potassium channels as being all over the place, the atria, the AV node, and the ventricles. I want you to think of calcium channels as predominating at the level of the AV node, and I want you to think of sodium channels as being most closely associated with ventricular conductivity. So if we give a calcium channel blocker, what we're doing is we're decreasing the transmission and conductivity of the AV node. We're decreasing the extent to which the AV node is going to transmit or conduct electrical impulses that arrive there. So what that's going to do is it's going to decrease the extent to which atrial impulses are conducted down to the ventricles. So when would we want to do this? Well, two primary situations. Number one, when we have AFib, which again, we have that storm of electrical activity going on up at the atria. If we kind of narrow the window that those electrical impulses have to be conducted down to the ventricles, will decrease the ventricular firing rate. And again, it's the ventricular firing rate that we're interested in controlling, because that's what's going to determine the heart rate. So, okay, that's one, when we have atrial fibrillation with rapid ventricular response. Another is again in that reentry loop SVT type situation, when we have an electrical impulse that is being redirected back through the AV node as soon as it passes through. We decrease the conductivity of the AV node. We have the potential to knock ourselves out of that reentry loop, which is what we're hoping to do. There is another piece that calcium channel blockers do provide, and that is vasodilation. So that's something that we need to keep in mind when if we're going to give these to patients that have low blood pressures. Calcium channel blockers are also going to dilate the vasculature. That means that if we have somebody who's got a low blood pressure to begin with, and we treat them with a calcium channel blocker, we could bottom them out. So we need to be super, super careful with that. And that is why we have precautions in our protocols for giving calcium channel blockers to patients who are hypotensive. One thing you might do is pre-medicate with a gram of calcium chloride before giving the calcium channel blocker. That tends to blunt the vasodilatory effects of the calcium channel blocker. Okay. So if epinephrine is our drug that is kind of the universal drug that can be used for any kind of a bradycardic rhythm, the counterpart for a tachycardic rhythm is amiodarone. So amiodarone, like epinephrine, acts at all levels of the heart. So what is amiodarone? Well, amiodarone is a sodium channel blocker. It is a calcium channel blocker. It is a beta blocker, and it is a potassium channel stabilizer. So it does all kinds of different things in the heart. It decreases the intrinsic firing rate of the SA node. It decreases the excitability and propensity to transmit electrical impulses at the level of the AV node, and it decreases the ventricular response at the level of the ventricles, right? It decreases the ventricular intrinsic firing rate. So two situations where we can use amiodarone are when we have SVT, because it'll decrease both atrial activity and transmission through the AV node, or atrial fib with rapid ventricular response, where we will decrease the propensity of the ventricles to respond to atrial impulses, as well as decrease the intensity of the atrial storm that's going on, and decrease the transmissibility of that storm through the AV node. Now, one thing you have to keep in mind with amiodarone is that for AFib, it does have a tendency to convert people back over into a sinus rhythm, because it has such a profound kind of normalizing effect on the way electricity runs through the heart. So if you have somebody with new onset AFib that is not anticoagulated, which means they're not taking a blood thinner, right? Remember that with AFib, you can have clots form in those fibrillating atria. And if you give them amiodarone has that tendency to convert them back into a sinus rhythm. If you convert them into a sinus rhythm before they're properly anticoagulated, you're going to cause a PE or a stroke, because your clots that have formed in those fibrillating atria are going to get ejected into the ventricles and then sent right up into the lungs or the brain, neither of which are places that we want to have a clot. So amiodarone is not really a good choice if you have new onset AFib in a patient that is not anticoagulated, because it's quite dangerous. It can convert the patient back over. So for those patients, what you really want to do, if at all possible, is what doctors call temporize the patient. Temporize comes from the Latin tempus for time. Buy them time. Give them some fluids, give them some oxygen, stabilize them, get them to the hospital so that they can get started on heparin, on other anticoagulants, and then when it is safe, when we have thinned out any clots that exist, then and only then will we give them something that could potentially convert them back over into a sinus rhythm. We don't want to do it hastily, because if we do, if there are any clots that have formed, they're going to cause problems for us. So something to keep in mind with amiodarone is that it lasts a long time. I have here one pharmacological intervention table, or one pharmacological information table, that is suggesting that the biological half-life of amiodarone is 58 days. That is a long, long time. So amiodarone is a very sticky drug. It sticks around in the patient's body for a long time. So do keep that in mind. It's a very blunt instrument. It does a lot of things, and it does them for a long time. So just keep that in mind. It's kind of like using I might liken it to using a bulldozer to dig up your garden. Could you do it effectively? Yes, it'll dig up the garden, but it's also going to do a lot of other things that maybe you don't intend for it to do. All right, so too ectopic. We've covered too fast. We've covered too slow. We're now on to too ectopic. So our drugs for heart rhythms that are too ectopic are amiodarone, sodium channel blockers, and magnesium sulfate. So let's get into this. When we talk about rhythms that are too ectopic, the big ones are VFib and VTach. So whereas we had this idea of AFib and we have this storm of electrical activity going on in the atria, for VFib, we have a storm of uncontrolled electrical activity going on in the ventricles. So we can give amiodarone in hopes of utilizing its effects of suppressing electrical activity in the ventricles. So decreasing the intensity of this ventricular storm and potentially converting the patient back over into an organized heart rhythm. That's what we're hoping to achieve with this. Another drug that can do the same thing is a sodium channel blocker. So our sodium channel blocker of choice in New York City is going to be lidocaine, and the dose for lidocaine is 100 milligrams. But other places might use a drug called procainamide, which is also a sodium channel blocker. And again, what these drugs do is they suppress the electrical activity in the ventricles by blocking sodium channels. And again, those sodium channels predominate in the ventricles. Notice that sodium channel blockers are more targeted. The lidocaine and the procainamide are more targeted than the amiodarone. Amiodarone suppresses activity in the atria and at the AV node. Sodium channel blockers like lidocaine and procainamide, exclusive sodium channel blockers like lidocaine and procainamide, just work at the level of the ventricles. So it's a more targeted therapy. So for that reason, you might consider using lidocaine over amiodarone, because lidocaine deals more directly with what's going on in VFib or VTAC without having extrinsic, potentially unwanted effects at other levels of the heart. So something to consider there. So mag sulfate is another important pharmacological intervention when we have uncontrolled ectopic electrical activity. So mag sulfate is used when we have a very specific type of ventricular arrhythmia called Torsades de Pointes. And with torsades, we have this polymorphic VTAC, right? So this sine wave pattern of polymorphic VTAC. This is caused by increased time that the ventricles are taking to repolarize. Again, delayed repolarization of the ventricles. Delayed repolarization shows up at baseline as a prolonged QT interval, which makes sense, right? Because the T wave is the ventricular repolarization, the Q wave is the depolarization. So if the QT is lengthened, what that's telling you is it's a longer time from depolarization to repolarization for your ventricles. So I want you to remember that for lidocaine and amiodarone, both of those drugs, especially amiodarone, less so lidocaine, both of those drugs prolong the QT further, particularly amiodarone and procainamide. Lidocaine is a reasonable option in this case, but the best option is mag sulfate. Mag sulfate decreases the time the ventricles take to repolarize. So you're going to have patients that are in either arrest or torsades with a pulse, and your protocol is going to say give amiodarone or lidocaine. Definitely do not give the amiodarone to these patients because it will make them worse. You can give the lidocaine, but what you should really do is contact online medical control and get orders for mag sulfate, because mag sulfate is the only drug we carry that is going to decrease the QT interval and actually address what is making these patients sick, which is a prolonged QT, prolonged ventricular repolarization. All right, so that's really what I had for you on this. Again, to sum up, if we go all the way back, we have three possible problems with the heart rhythm. It's either too slow, it's too fast, or it's too ectopic. If it's too slow, we could give atropine, which will increase the firing rate of the SA node, but it won't work on second degree, type 2, or third degree heart block because the SA node isn't determining the heart rate. We could give epinephrine, which will increase activity at the SA node, at the AV node, and in the ventricles, as well as causing vasoconstriction. We could give the dose-dependent dopamine, which is old-fashioned, but does increase the firing rate of the SA node, conductivity through the AV node, and the ventricular rate, as well as causing vasoconstriction, similar to epinephrine. We could give norepinephrine to just increase the blood pressure without affecting the heart rate. We could also consider giving calcium chloride or sodium bicarb if we have an underlying condition like hyperkalemia or acidosis that we want to correct. And calcium chloride and sodium bicarb will help us with those underlying conditions of hyperkalemia and acidosis and help restore normal activity through the heart. But we're going to be careful when we give our calcium and our bicarb because we don't want to combine them and make chalk. So we're going to give them either in two separate lines or with a nice 20 cc saline flush in between. All right, so for our two fast rhythms, we have adenosine, which we'll use for stable SVT, and that'll block reentry at the AV node and knock us out of that SVT rhythm. We could use a beta blocker to slow down atrial activity, but we'll be careful with beta blockers in patients that may have asthma or COPD. We can give a calcium channel blocker like diltiazem to suppress conductivity at the level of the AV node and control our rate with AFib or SVT. We could give amiodarone, which is going to suppress activity at all levels of the heart, in the atria, at the AV node, and in the ventricles. It's going to lead to decreased conductivity, decreased reentry for SVT, decreased atrial activity and transmission of atrial activity in AFib with rapid ventricular response. But we're going to remember with amiodarone that it does have a tendency to convert patients into a sinus rhythm. And so we're only going to be using this when we're confident that our patient is on anticoagulants and that they don't have clots that have formed in their fibrillating atria. We're going to remember amiodarone lasts a long time in the body. And then we're going to think about our rhythms that are too ectopic. So again, for ectopic rhythms, we have amiodarone, which is going to suppress ventricular activity. We're going to have, in addition to that, we're going to have sodium channel blockers like lidocaine or procainamide, both of which will suppress activity in the ventricles. All right, so again, our sodium channel blockers are going to suppress ventricular activity, particularly when we have inappropriate activity in the ventricles like VFib or VTAC. And then we're going to reduce that intensity and hopefully allow us to restore a normal ventricular rhythm. And then finally, when we have delayed ventricular repolarization, we can give mag sulfate, which will decrease the time to repolarize, give us faster repolarization, and allow us to correct the conditions that are underlying torsades, state point, and restore a normal heart rhythm. So those are the drugs that you as a paramedic need to be aware of to correct an abnormal heart rhythm. Whenever you're giving these drugs, I want you to keep in mind the goal you're hoping to achieve, right? So, for example, if you have a bradycardic patient, your goal is to increase the heart rate and restore normal cardiac output. So would you ever want to give a drug that, for example, decreases ventricular activity like amiodarone for bradycardia? No, never. You would never give a drug like amiodarone that decreases ventricular activity when the heart is already bradycardic, right? Similarly, if you have a heart that is too tachycardic, like in SVT, you would never give atropine for SVT because that's just going to further increase the heart rate, right? So always keep in mind what you're hoping to achieve by giving this drug. Know what the drugs do and know what effect you're looking for in giving them. That's what you need to know. I hope this has been helpful. I'm here for you guys if you have any questions.